All right. So, in honor of my new friend Mitchell, who's a prompt person as well, I think we'll go ahead and get these housekeeping and intro things kind of out of the way here promptly at once, so we can get going into the presentation and everything. So, I just want to say hello and welcome everybody here to the 2021 Intermountain Tribal and Rural Opioid Wellness Summit breakout session. So this is one of those breakout sessions away from some of the main ones where everyone's grouped. So the session today that we're going through here is it's titled Enhancing Prenatal Care in Rural Utah Communities. And we have our lovely presenters here today, Mitchell Garets, Jake Baylis, Shayla Archer, and Ari Bryan of the University of Utah School of Medicine, PARCKA uh, PARCKA team. I hope I'm saying that right. I'm a big fan. I've attended some of the webinars that have been put on. So I'm glad to be the moderator of this session and from these representatives from this great organization. So I'm going to be the moderator. My name is Nayufi Iongi. I'm from the Department of Substance Abuse and Mental Health with the Opioid team. So throughout this, I'll be available in the chat box at any time. Feel free to ask questions, get any clarification directed at me or the panelists or anyone. So before we get started, just a few quick housekeeping things. So in this breakout session, it is being recorded. So just remember some of the content may be reproduced or broadcast later. So please, don't do anything that'll be embarrassing or that you'll look back on and frown. So if for any other reason you want to remain anonymous in this session because it is being recorded, I'll put here in the chat box some instructions if you do want to be anonymous. It's just basically change your name and then go off video. So that's the basic steps for that. But that in the chat is available if you need that. If you need any help with that, feel free to send me a message and I can help you out with that. So if at any time during this presentation, you have any questions, use the raise hand function of your Zoom, which is found there on your screen, or if you have any questions, type it in the chat box. Everyone will be automatically muted, but I can turn the mic on if you do want to ask the question verbally. That's always awesome, so just let me know and I can do that for you. All right, long-winded, some housekeeping stuff. I hope you're still with me here. But I'd like to introduce our guests for today. I'm excited to hear from everybody. So first, I'd like to introduce Mitchell Garets. Mitchell is a research analyst at the University of Utah's Department of Internal Medicine, Division of Epidemiology, with the Program for Addiction Research, Clinical Care, Knowledge, and Advocacy. That's our PARCKA acronym. I love it. Mitchell holds both a bachelor and master's degree in social work from the University of Utah. Mitchell has several years experience working in substance use disorder research and treatment and has offered research support and or coordination on several local and national funded multi-site studies. Oh, impressive, all right. He has several years experience in providing direct clinical and case management services to pregnant individuals with substance use disorders. Thank you for being here, Mitchell. We're glad you're here and excited to hear from you. But next up, I'm going to reintroduce the whole team. So next up is Jacob Baylis. Jacob is a research analyst and program manager for the Salt Lake City VAHCS. I haven't quite heard that one yet. You may need to explain that one later, Jacob, but that's all right. And the PARCKA team at the University of Utah. He currently manages the Stepped Care for Opioid Use Train the Trainer initiative and has also worked on an evaluation of a specialty clinic in the Salt Lake City VA Medical Center. He looks forward to furthering his career in evaluation and in implementation research. Thanks for being here, Jacob. Again, impressive stuff. And then we have Shayla Archer. Shayla works as an administrative program coordinator at the University of Utah in the Division of Epidemiology and PARCKA. Shayla has been involved in social behavioral research since 2014. Her education and background includes BS in psychology from the University of Utah's College of Social and Behavioral Science and an MS in health promotion and education from the University of Utah College of Health. Man, everyone's so impressive here. And so yeah, last but not certainly least is Ari Bryan. So Ari received a Bachelor's of Science and Master's of Social Work from the University of Michigan. Ari has been involved in substance use disorder research since 2011 and is a certified social worker. Her research interests include medication and behavioral interventions for substance use disorders, rural healthcare delivery, and implementation science. Wow, each person has such an impressive background. We're lucky to hear from each of you today. So Mitchell, Jake, Shayla, and Ari, we really appreciate you joining with us. So we have the title slide up on the presentation. Again, I'll be available with throughout the presentation if any questions or support is needed. And with that, I will turn it over to who is up first.
I just want to first say thank you. That was I don't know about the three of you, but I was like, whoa, we need to take you everywhere I go to feel better about what I've been doing, so thank you. Yeah, if we can go ahead and jump in and get started. I think the four of us talked last week, and the first time we did this presentation, it was definitely more presentation style, but I think all four of us like that Q&A. So we might go through the slides pretty quick and then just kind of leave some time just to talk as a group. So we can go ahead and move to the next slide. All right, so the agenda may look long, but it's not that bad, I promise. So we've already introduced ourselves. We'll kind of give a background on the Carbon and Emery County, and then Jake's going to go over a couple things. I'll talk about some stigma alleviation. Shayla will then talk about what we did in San Juan County last year, and then I'll talk about what we're doing now. There are some people here, like a Lynn Mitchell that I just saw yesterday in San Juan. So I'm really glad you're here, and I won't embarrass you too much, but if you want to say something about San Juan in the second year, please chime in. And then Ari will also give some other stuff about Carbon and Emery County, because she kind of put together the protocol and all that at the time. And we can move to the next slide. All right, and before we get started, we just want to say that this project did happen at PARCKA. I'm not going to go through the long thing again, but just PARCKA, and our PIs were Dr. Gerald Cochran, Dr. Marcella Smith, and Dr. Taylor Kelly. And this project was funded by the Utah Division of Substance Abuse and Mental Health, and we do not have any disclosures.
Okay, and I can jump in here. Hi, everybody. Thanks again for having us. I'm just going to give a little bit of background around the initial part of the study that we did in Carbon and Emery counties. So we chose to work with this community, first of all, just because of the need around opioid use disorder treatment. Obviously, or as many people know, there were pretty high rates of opioid-related deaths in Carbon and Emery counties, so about almost 50 deaths per 100,000 people compared to about 17 deaths per 100,000 in the rest of the state of Utah. So there was a high need there, but then also some really important and unique characteristics about the community was really the high level of pre-existing community engagement. There was a lot that the community had already done and a lot of support happening and activism around solving this problem and helping community members. So that really made this kind of an attractive group to work with and really an easy group to work with when they've already done so much. And another piece that kind of prompted this project was the relationship that our principal investigators, so Drs. Marcel Smith and Gerald Cochran, had with Dr. Danelle Pendergrass, who runs Eastern Utah Women's Health, which really became our epicenter of care. And really, I want to say Danelle was really key to this project. I mean, she really kind of helped come up with the project itself and did so much to make it successful. So I think those are really the characteristics that allowed this project to happen, and made it a place where we really wanted to see how we could be helpful. So we can move on to the next slide from there. And then I'll just go briefly over the methods. So this was largely, there were 3 prongs to this project. So the first one was enhancing prenatal and postpartum care. And after talking with the community a bit and just kind of brainstorming, what this ended up looking like was largely implementing a patient navigator into Eastern Utah Women's Health. And this was a woman who was from the area and knew the community really well and was just a huge asset. And she was able to really help facilitate transfers to other forms of care. So women who came in, first of all, she helped with the recruitment process of engaging women in the community who were struggling with opioid use disorder and were pregnant or had recently had a baby. And she was able to plug them into care with Danelle. And then from there, really work to case manage and problem solve and connect them with any other available resources into the community or that we could provide through the study. And so she was really essential to making this project work. And then the next arm was educating our community providers. So we did this through an initial kickoff event, and then we also had monthly webinars where we had different clinicians here at the University of Utah present on their areas of expertise. And so the presentations were on things like the treatment of neonatal opioid withdrawal syndrome, so NOWS, as many of you may know. Also things like prescribing buprenorphine for pregnant or postpartum women. And also we had some education on screening, brief intervention, and referral to treatment, so SBIRT, that could be implemented into the different clinics and just community settings in this study. And then the more implementation sciencey piece is next. So we had 2 different implementation frameworks that we use. So the first one is called the Consolidated Framework for Implementation Research, so CFIR. And we did this to kind of assess some of the implementation barriers and facilitators in the area. So what we did is we did 3 time points of mixed method interviews with many community members at different levels. So this included healthcare providers, this included patient advocates, social workers at DCFS and things like that. And they really gave us some more information on what was going on in the community, what the needs were, what resources already existed, what the attitudes were as well in terms of bringing in this intervention and things like that. And then REAIM is more to evaluate at the end of the study, the success of the study. So REAIM stands for Reach, Efficacy, Adoption, Implementation, and Maintenance. So it allowed us to look at how well is the information that we're trying to deliver being taken up by the healthcare providers in the community and what isn't working. And also the maintenance piece really helps us evaluate, can this be carried out once the research team leaves? So that is, that's the end of the slide. You can go right on to the next one.
All right, I would also like to thank you for the kind introduction at the beginning here. My name's Jake. I'm going to go over some of the data stuff, and I don't know how familiar you all are with data and p-values and that sort of thing, so I'm going to try to take it right down the middle. So if you need more explanation or anything like that, feel free to look at or type in the chat. I'm looking at that as I'm presenting here. I'm going to go over a survey that we did. As Ari mentioned, one of our approaches was to educate community partners. And one way to understand what providers already are proficient in or may need additional training in was through a survey. So we created an online survey on REDCap and sent it to all health and behavioral health care providers in Carbon and Emery counties listed in Utah's professional database. Objectives of this survey were to evaluate healthcare provider perceptions and attitudes towards providing care to patients with prenatal opioid use disorder, or OUD, and to identify any associations for negative and positive perceptions and attitudes towards pregnant women with OUD. So we sent follow-up survey invites every week for 8 weeks to try to get as many providers as we possibly could to respond. And at the end of the 8-week period, we had a total of 225 providers consent to participate in the survey, which was a 52% response rate, which we were very happy with. It should also be mentioned providers that did complete the survey were compensated for their time. So there was, a little bit of a incentive to complete the survey. We collected a lot of information, including demographics and information on continuing education, clinical practice, and provider competence on a variety of topics. Now to get to some of the numbers here, we, out of the 225 providers that consented to the survey, 53 responded. They provide medical or behavioral health care to pregnant women who may misuse opioids. So the focus of this, this slide and the following slide and the tables here are just going to be from those 53 respondents. They answered a variety of questions, including the Survey of Attitudes and Perceptions, or the SAP, which was adapted for opioid use. The scores ranged from 10 to 70, 10 being the most negative and 70 being the most positive. So in an ideal world, everyone has a perfect positive attitude on working with pregnant women with opioid use disorder, but we understand that is not the case. So as close to 70 as possible was seen as good. We analyzed the mean scores of the professions here. You can see in table 1 using an ANOVA test, and we found a significant difference between professions with an overall mean of 52.1. You can see the p-value is less than 0.05, which means it was significant. Looking at the scores here, you can see nurse practitioners and nurse midwives had the highest or most positive score of almost 60 there. And nurses had the lowest average score of 47.8. I did think it was interesting. Nurses responded the most out of all the providers, which probably makes sense because there's probably more nurses than other types of providers. I think 22 of the 53 were nurses. So the majority of them were nurses, and they averaged out to have the lowest attitude score. We can go ahead and go to the next slide. Thank you. We then conducted linear regression analyses, which basically was to look at potential variables contributing to their scores. The far left column you can see is adjusted, which we'll focus on a little bit, but we're going to mainly focus on the adjusted column on the far right there. The left column is the variables, and they're written out there, and you can take a look, but they're divided into 3 categories: continuing education, clinical practice, and provider competence. Looking at the results, any beta value, or it looks like a fancy B right there, with an asterisk next to it, was found to be significant. The more asterisks, the more significant it was. In the unadjusted column, we had 10 of the 14 variables there were found to be significantly impacting providers' perception and attitude scores. You can see the highest one is 6.49, and the first variable under provider competence, provider skill in asking pregnant patients about opioid use. And a simple way to kind of understand what that 6.49 means is 1 unit change in the positive direction. So the more skilled providers feel in asking pregnant patients about opioid use, 1 unit change in feeling more skilled results in 6.49 units higher of an attitude score. So that one was quite a bit, was the most significant and had the highest beta value there. So it impacted the attitude scores quite a bit. Wendy, can you advance one more here? So I put some boxes around some of the adjusted columns. And we adjusted for demographics, which was professional discipline, highest level of education, and years working in current field. All of the significant ones in the adjusted were also significant in the unadjusted, which makes sense, but there's a few less. You can see the provider competence, they all remained significant as we adjusted for demographics. The variable with the largest beta value in both, you can see, was one I kind of already touched on, the skill in asking pregnant patients about opioid use. It was almost, when we adjusted for it, their attitude scores almost increased by 5 the more confident or skilled they were in asking pregnant patients about opioid use. It seems like a fairly easy thing to do, but sometimes, we're all, there's sometimes questions I don't ask because I don't know how to respond if they were to say yes or no or answer in a certain way. So that might be part of the reason why the response was as it was. As you can see, the only other significant variable is the hours of professional prenatal opioid education at the top there, which all of these significant variables go hand in hand, as prenatal opioid education will likely increase providers' competence when treating pregnant patients with opioid use disorder. As it was shown on the previous slide, profession displayed a significant difference in providers' attitude scores. This underlines the importance of all healthcare professions that may treat pregnant patients with OUD receive opioid education, specifically prenatal opioid education. This can be done to reduce negative perceptions and attitudes towards pregnant women with OUD and provide less stigmatized care for pregnant women seeking care, especially in rural areas where resources and treatment options are limited, as I'm sure you are all aware. You can go to the next slide.
Okay, so if we think back to just a few minutes ago with Ari, when she explained the interventions and the 3-arm approach, stigma and barriers weren't really one of them, but the work we were doing, it would make sense, right? That increased education, putting in a patient navigator. I think we also hired someone in Emery County with USARA. So some of our monthly education topics were around stigma. So we were like, it would make sense. So it may have not been one of the outcomes we were anticipating, but we wanted to see if stigma and barrier alleviation did happen through our interventions. So first, that's a lot of words, but really all we did was we did 16 qualitative interviews where we sat down with community stakeholders in the counties to just kind of talk about if they have seen any changes in stigma. These questions were designed using the CFIR that Ari mentioned, and we assessed this twice through the intervention period at the mid-intervention point and the post-intervention point. And again, we weren't specifically doing that to see stigma. That's pretty normal in a study, as you probably all are aware, to do fidelity monitoring at the midpoint and post. But we did sprinkle in some stigma and changes in attitudes questions to kind of see it. And then we did the data analysis to kind of see. So we coded the data by 2 coders, myself and Amy Kinney, who is not here today, but the 2 of us were able to use the RITA method, which is the rapid identification of themes from audio recordings. And coding was designed to capture improvements in the topic areas addressed with the CFIR questions. And the frequencies are presented for counts of themes that I'll go over in the next slide. Okay, so as we can see, there was a huge change in stigma and barrier alleviation that we were really happy to see. So on the left side, it's kind of small. Do you share these slides afterwards? If someone were to, is that something we do?
I think we can.
Okay, yeah, if anyone wants to see these like up close and personal, where it's not so small, we're more than happy to share them. So we did, on the left side was quotes from the interviews. So it was indicated that more discussions about if somebody is pregnant and using opioids, instead of shaming them or you just need to stop, there's more conversations about what we can do to help. We saw that there was improvement in community. As Ari mentioned, this community is resilient and all those connections were already there. We didn't go in and really create any new resources, but we're happy to see that we help connect the dots a little bit. And then improvements in family. It was found to be a generational program, and that's kind of the core of this work with pregnant individuals, right, that we're hoping this will be a generational change. And on the side, again, it looks like similar to Jacob's tables, but we see agreement between myself and Amy, the two coders, and to see how often these themes are coming up. So we see that there was improvements in attitude and stigma, improvements in treatment changes, even small for me, improvements in community, and so on. So that was just a great side piece of, okay, we have these three barriers, but what else did we do? So we were really pleased to see this. Oh, and we can go to the next slide. Yeah.
Okay, so I'm going to talk a little bit about what we took from Carbon and EMERY and basically transplanted into San Juan County to see if we could kind of cultivate some of the same benefits in San Juan as we were seeing in Carbon and EMERY counties. So we were interested in looking at San Juan County because the demographics of the population in San Juan County are very nearly split between Native American and white. And we know that these are the two groups in the United States that have the highest rates of opioid overdose death. So similar to Carbon County, we could tell that this area might be somewhere that we might want to look closely at. Utah has one of the highest rates in the country of opioid prescriptions filled by pregnant women. And as I said, surrounding counties such as Carbon and EMERY have high rates of prescribing to pregnant women and opioid use disorder related harms. So what we did here was a needs assessment with the objective to identify implementation needs, facilitators, and barriers for opioid use disorder treatment in pregnancy in rural, racially diverse communities. Next slide, please. So we did a mixed methods cross-sectional needs assessment in San Juan County. This included windshield surveys, which are observational assessments of the needs and barriers to accessing care within the community. We also included an unannounced standardized patient interaction piece, and that essentially broke down to phone calls to clinics as patients presenting with opioid use disorder to kind of understand the actual patient experience in accessing care. And then we also, similar to Carbon and EMERY, we did a quantitative survey, which was an electronic survey, as you've heard about in earlier slides, and then qualitative interviews. Again, same thing as Mitch went over, where we did purposive sampling of healthcare providers and patient advocates in the area. Next slide. Thank you. So our primary findings, our windshield surveys helped us understand that there's a lack of public transportation in San Juan County, and that may be a pretty substantial barrier to treatment engagement for folks. And kind of related to that, we realized that depending on location, individuals may be needing to travel multiple hours to access treatment, depending on where they are within the county. In terms of the results from our unannounced standardized patient interaction piece, we found that buprenorphine treatment is available at only 3 clinics of 6 surveyed. And we found that referrals for treatment were really inconsistent and were sometimes up to 5 hours away or potentially out of state. So it really just helped us understand that there may be just a discrepancy in knowing where to refer and what options are available for patients with opioid use disorder in the county. Next slide. The results from our quantitative survey and qualitative interviews are, I'm breaking them down a little bit differently than Jacob and Mitch did for Carbon and EMERY, but they're really quite similar. We had a 33% response rate, which was lower than Carbon and EMERY. But our participants similarly broke down. There were the most people were nurses, and then counselors and therapists, physician assistants and physicians, and then individuals who identified themselves as none of the above or other. 41% of respondents stated that they provide medical or behavioral health care to pregnant women who misuse opioids, and 65% see at least one pregnant patient with active opioid use disorder per month. 66% of respondents stated that they rarely or never use a formal OUD screener with pregnant women, and nearly 50% of respondents rarely or never refer pregnant women with opioid use disorder to treatment. This was really good information for us to have. And really kind of lined up well with what we were hearing in the qualitative interviews. Our coding resulted in the most referenced themes of resources are needed. Folks mentioned that long-term funding for education and prevention are really needed. One person, I pulled this quote, said, we have people to do this work, we just need funding. We also heard that substance use of methamphetamine, marijuana, and alcohol, which includes Listerine, rubbing alcohol, and hand sanitizer, was a really commonly referenced theme, as well as some information on cultural differences between individuals living on the reservation versus not living on the reservation, and vocalization of a need for culturally appropriate care for those folks on the reservation to address this issue. We also did hear that substance use of opioids was a commonly mentioned theme, and finally barriers to treatment, availability of existing resources was also mentioned frequently. I think this might be, okay. That might have been the wrong direction. Yes, thank you. And so Mitch will now take us through what's going on in San Juan County today.
Great. Yeah, I'm really excited that I get to talk about this because I just got back from landing last night. So the kind of with Shayla mentioned with the needs assessment, it was initially just a needs assessment, and then our funders were like, hey, do you want to do this work in San Juan County? And we were like, absolutely, but maybe with a little bit of changes. So we found in the needs assessment that Carbon and Emory was strictly OUD, but we found through these interviews in San Juan County that there's a lot going on there. So it's not strictly OUD. We're also looking at substance use disorder as a whole. So meth, alcohol, tobacco, and we really wanted to use these findings to develop a community-based intervention for treating SUD in that specific county. So far in the last 6 months, we've partnered with San Juan Counseling and the SJC PAC, and Ellen Mitchell leads that, and she's here on the call. And Ellen, we talked about we couldn't have done the last project without Danelle. We couldn't have done this next step without you. I know you helped Shayla a lot organize those. So shout out to Ellen who's here. We also have done protocol and education curriculum development. That's in process right now. We've met with topical experts around that, and we're incorporating that feedback right now. And we've met with over 60 community stakeholders. So I think we're on a good path, and that's what we've been doing this year. And we can go to the next slide to talk about what we're going to be doing this next year. So beginning fall 2021, we're going to partner with several clinics and agencies to, one, increase perinatal addiction education, increase SUD screening and referral to treatment. Nothing that Shayla said was to say that the providers in San Juan County are not doing this work. It's just they may not have the tools or the time, things going on. So kind of seeing how we can put these tools in place and how screening can be brief. So we're relooking at SBIRT where it doesn't have to be so overwhelming. And then we're going to collect and analyze data to further this type of research and treatment. And again, this will probably start in October. And I'm hoping we can probably have these last 10, 15 minutes for questions.
Yeah, that sounds perfect. Let's, I guess just a quick thing that I've noticed. I love this setup of pieces but united. That was an interesting thing to see how each of you had these different focuses and areas that kind of mended together into this, larger mission. And so, for the people that are here in attendance, if you do have a question, you can put it out there generally, and hopefully someone could pick that up. But if you do have a specific question for like a Jacob or Shayla or whoever, please direct it at them. So I guess as people kind of get those questions formulated, the one that I think came to my mind as I've listened, to kind of get us kicked off was, and I guess this goes to whoever wants to pick it up, but what would you say like the biggest challenge has been in this project so far? It could be one that you've seen kind of across the different projects, or maybe one that you saw in your individual project, but maybe kind of share with us some of those challenges that came along, and your experience that came from that.
I can speak to that a little bit. One barrier that came up that seems like it should be a really simple fix, but wasn't, was transportation in Carbon and Emery counties, especially in Emery County. It was really difficult to get patients to Eastern Utah Women's Health and kind of the other resources that were nearby. And again in the interviews, it came up that transportation is a barrier for people. But the way our funding was and whatnot, it made it really difficult to actually get that set up. And it honestly was still something that I think we struggled to address even at the end of the project. And many of the people who had been, have been living in Emery County and Carbon County for a while had figured out ways around of, carpooling with friends and stuff, but it was still really difficult and something that, we really struggled to be able to implement.
Really, did they innovate that themselves with the carpooling and kind of ride sharing type stuff, or was that a suggestion?
No, it was something that people were already doing. I mean, I think we were able to come in and, like Mitch said, kind of like connect some of the pre-existing resources and whatnot, but there was so much that the community was already doing. So yeah, people had already kind of figured out how to navigate the system that they were in. And honestly, when I think about our project, I know there was the hope of, when we did this first project in Carbon and Emery counties, of course, to take some of those pieces and implement them in San Juan, and then maybe other places in the state or even other rural communities in the country. And I think what has been so interesting is it's not so much like what we're coming in and doing, it's almost like we're just learning all these things that the community is already doing really well. And that's what can be implemented in other areas. So yeah, that was definitely something that people were already doing on their own without us or without our intervention.
That's awesome. Go ahead, Jacob.
Yeah, so I will echo what Ari said there as well. Transportation for sure was brought up several times. And like she said, there was some transportation arrangements kind of already established. I know one of the centers in San Juan provides transportation, but a lot of patients don't know that necessarily. And so, like she said, connecting the dots with people and to resources was part of it. But an overarching and overwhelming challenge was COVID. And because it hit right kind of when this project was going, and that transportation was not as huge of an issue in some aspects, but virtual visits might have been, and access to phone or a tablet or a computer or that sort of thing. It really changed the shape of part of our evaluation efforts here, and rocked all of the clinicians' worlds that we were working with. So yeah, that was definitely an issue.
I think along those lines, a big one for me was we didn't have the enrollment numbers that I think we were anticipating. I think there was a lot of discussion that, oh, there's going to be so many women that need help, and you better be ready when you kick off, and we kicked off, and I think we had 5 like on our hand, and it wasn't a matter of, oh, they were wrong, they don't exist. It's like, are we not reaching them? Like, how are we not getting there? And kind of having to shift the project halfway through of kind of like, okay, what we're doing is obviously not translating, you know, so what can we do? Like if these women aren't feeling safe or comfortable coming, can we, maybe that shifts to how can we educate the providers to create those spaces that feel safe and feel accessible? And then the other one I think is, born and raised in Salt Lake, and I've never ventured much out of Salt Lake until the last couple of years. And I just think Utah's Utah, you know, and like Ari said, we wanted to venture into other places, but from going to even Carbon and Emery counties to San Juan, the needs are so different, and they're touching, you know, and the needs in Salt Lake are so different. So there really is that tailoring aspect that has to be done every time, you know, of like, okay, what worked in Carbon and Emery County may not work here, or it could, but it's going to have to look completely different. And that's been a challenge.
These are amazing. Do you have anything you want to share, Shayla? Are you okay? You good?
I think I'm good. Thank you.
All right, sounds good. All right, so we have about 10 minutes left. I haven't seen any other questions come rolling in, but I'm full of them, so don't worry about that. So I guess this one will roll into each other. So in choosing your sample, beginning with Carbon in Emery County, then going to San Juan, can you kind of tell us what went into that decision? Why did you choose those? How did that turn out? In kind of that thread, and then kind of going from there, how do you see the future of prenatal care related to opioid and substance use in these rural communities in Utah? How do you see the issue evolving? What do you see in the next 5 years or even further as you look down the road?
I can speak a little bit to the second part of the question. And yeah, in terms of selecting the sample, the other speakers may have more information. And a lot of that I think was decided by Doctors Cochran and Smith, who kind of, you know, got the funding for the project. But I think in terms of the future of perinatal opioid use disorder care and substance use disorder care, I mean, first of all, I think is with the education and kind of reducing stigma, I think a lot of that work is not necessarily that people, you know, just, yeah, I guess reducing stigma, and I think reducing those misunderstandings of, I think we've heard messaging of people being sometimes like afraid to put pregnant women on medications for their opioid use disorder, and understanding how necessary and how important for long-term outcomes that is for both the health of the mom and the baby. So I think really just treating this as a medical issue rather than us shying away from it or creating it as, you know, allowing it to be a legal issue or a moral issue, and treating it as something medical that deserves compassion, just like any other, you know, health issue that pregnant women deal with. And Dr. Marcella Smith, I wish she was here because she could speak to the medical piece a lot more than the rest of us, since that's really her area of expertise. But I think that's what I would envision for the future of perinatal OUD treatment.
Yeah, perfect. Any other thoughts from the rest of the team? Jacob?
I can also speak on the latter portion of that question. In the past few months, the Health and Human Services, or HHS, has come out with some new guidance on initiating buprenorphine or Suboxone, or these opioid use medication for opioid use disorder. So clinicians previously who could prescribe these medications had to do this extensive training, but the laws and policies are changing as we speak. And so within the next few months, it'll be a whole lot easier. It already is since, I think, April, since last month. It's a lot easier for providers who can prescribe with up to 30 people or that sort of thing. It's changing. So I think all this to say, the policies at the federal level are changing to allow providers to provide or prescribe a lot easier. So then it becomes really important to educate these providers on how to initiate treatment, because that's why a lot of providers are not providing or starting care on people, because they're afraid they're going to do it wrong, or if they're going to, you know, cause a lot of pain or harm to this person. But so I think training is going to be a big aspect coming up.
And I don't have much more to share to the second part because I was like, yes, Ari, yes, you know, when she was going. But the first part, if you, just to clarify, you were why we decided on this population. I think it came from Dr. Smith. She runs her own specialty prenatal clinic in Salt Lake, the SuperAd clinic. You three, if you want to know the full name, will have to help me for what SuperAd stands for, but Ari's thinking, but well, it's just, do you want to give it a shot?
Oh, I don't know it for sure. I think it's substance use, pregnancy, recovery, education, clinical care. I don't know. I think I maybe butchered the last few letters, but SuperAd stands for something like that.
Yeah, and it's a prenatal clinic, especially for pregnant individuals with a substance use disorder. Oh, Jacob, not feeling brave enough to say it. No, but it was great. Yeah. Oh, thanks, Megan. So I think that started, and then our wonderful partners at the state were like, how can we get the ideology of SuperAd out into these rural spaces, you know? So that's kind of where it came from. And Dr. Cochran has been doing this work for a long time too. And that's kind of where it came from. And the data Ari shared, looking at these overdose deaths and that kind of stuff.
And I think the San Juan piece was kind of like really it became like a sister project. It was like all started in Carbon and Emory, and that was the original funding source, and really where Marcella, Dr. Smith and Dr. Cochran kind of focused their efforts. And then because San Juan is, as Mitch mentioned, just touching Carbon and Emory counties, and also has this really interesting demographic that makes it really worth watching and worth paying attention to. I think it was just kind of a natural continuation.
All right, perfect. Well, yeah, we got about 3 minutes left. I think I'll save you on the questions. We'll end at 1:50, but you know, I just wanted to say I appreciate the work that's been done here. I mean, this is how change is made. This is how progress is made, and you know, you're capturing the lives of these people, both as in the provider aspect and the patient aspect, and this is such a important population, both in that rural aspect, but also, you know, mothers, you know, expecting mothers, and you know, kind of how this can make an impact at that kind of critical juncture of a life, not only for that mother, but for that baby, you know, and that's so important. So I appreciate this work and everything that's been done here, and the stories that have been told through the numbers and the quotes and all that stuff. It's a grind to gather those, but I appreciate you know, not only gathering those, but sharing that with us. So I hope in our rural communities we can continue to improve and you know, see the progress, because I think that I saw it here today. So so for everyone, so thanks to our panel today. Let me get into the closing stuff here. Let me get up my script here. So yeah, thank you everybody for joining us today in our Enhancing Prenatal Care in Rural Utah breakout session. It's brought to you by the Utah Department of Human Services, Division of Substance Abuse and Mental Health, the Rural Health Association of Utah, Utah State University, and the Emma Eccles Jones College of Education and Human Services Department of Kinesiology. I hope I said that right. I probably didn't. And Health Sciences, and the USU College of Humanity and Social Sciences, USU Extension, and our federal partner, SAMHSA. So please, everybody, you know, let us know how you're practicing these concepts and how this information's impacted you on social media with these hashtags I'm putting in the chat. You know, go ahead and share that there. And just remember that the main room is always available, you know, outside of these breakout sessions. And I will put the link up here. and you can go in through there. The biggest thing that they have to remind you about is tomorrow we have a live episode of the Debunked podcast with a panel focused on mental health, incarceration, and recovery. We have a goose chase scavenger hunt that looks fun, and closing remarks by Utah State University Vice President Dr. Ken White. So it's really focused on tomorrow, but I think we have another session here after this. So just make sure to log in your sessions a little bit early and enjoy these, because I know that I really enjoyed this one. So with that, we can end here today. Again, thank you to our panelists and everybody that attended here today. Appreciate it and have a good day.
Thanks, everyone.
Thanks for having us.
Thank you.
Yeah.